first 2 to 3 years. Lower intelligence quotient and decreased performance in executive function, language, fine motor, and visual motor skills at school age, and increase rates of psychosocial maladjustment and educational needs. And there will be lower rates of major disabilities such as cerebral palsy, severe intellectual disability, significant visual impairment, or sensory neural hearing loss. The neurodevelopmental dysfunction rates, the highest risk is among the hypoplastic left heart syndrome and related abnormalities. Neurodevelopmental deficit apparent only at school age, and long-term follow-up of these children is critical. So we see one by one according to the diseases. First, we see the factors associated with the risk of adverse neurodevelopmental outcomes in children with the CSD. Patient factors are the genetic polymorphism. There will be the 22q11 microdeletion and other genetic syndromes such as preoperative microcephaly, preoperative abnormal neurological examination, preoperative intubation, and the demographic factors such as low maternal or paternal educational level, socioeconomic status, and the perinatal factors such as low birth weight and low gestational age and poor condition at birth. Perioperative factors such as postoperative seizures, abnormal neonatal magnetic resonance imaging, long postoperative hospital stay, need for additional surgeries, or prolonged deep hypothermic circulatory arrest, and high preoperative plasma lactate or low oxygen saturation. In case of HLHS and other form of functionally univentricular heart defects, assessment at 12 to 14 months shows that many children score significantly lower than the normal population on the Bayley's infant developmental scale. And at this young age, a motor development is usually more impaired than the cognitive development. And by school age, these children show high rates of gross and fine motor dysfunction and lower cognitive and adaptive behavioral score. Brain abnormalities, mainly ischemic changes of different severities, have been identified on the follow-up MRI scans in in those with an abnormal neurological examination, lower IQ, and worse motor performance. In case of TGA, good immediate and long-term survival rates, and despite having IQ scores close to the population average, children with the postnatally corrected TGA require more academic support and special education services than their peers. There will be deficit in the motor disability and visual special skills, language disorder, executive function at school age, and increased risk of behavioral problems. In case of TOF, the main factor affecting the outcome is associated with genetic syndrome and chromosomal abnormalities. In children with TOF but without a genetic syndrome, at school age, there will be the high rate of impaired motor coordination, sensory motor function, suboptimal IQ, language difficulty, and attention problem. And the developmental score at 1 year are lower than those of the normal control, but tend to be within one standard deviation, with few children scoring 2 standard deviation below the normal. This table shows the different cardiac defects with percentages of abnormal developmental outcomes. In case of HLHS, in short term, there will be the psychomotor developmental index less than 70 and mental developmental index less than 70. And school age abnormal neurological examination is around 70% and abnormal motor function is around 32%. They have mean IQ of around 95 to 97%. And in case of TGA, the psychomotor developmental index less than 70 in case of 6%, less than 85% in 21%, and mental developmental index is less than 70 in case of 17%. At school age, The abnormal neurological examination seen is 65 to 70%, mostly mild, and the mean IQ will be the 88 to 99. The IQ less than 70 in case in 3% of patient, and visual spatial score less than -1 standard deviation in 32 to 42% patients. And in adolescents, the mean IQ will be 89 to 96%. In case of TOF, the psychomotor developmental index less than 70 in case of around 23%, and mental developmental index less than 70 in up to 8%. Mean IQ will be 90 to 103. And abnormal neurological examination found in around 45%. In case of atrioventricular septal defect, the mean IQ will be 93 to 102, and the abnormal neurological examination in 20%. In case of TAPVC, the PDI less than 70 in 7%, and mental developmental index less than 70 in 13%. The mean IQ will be 95, and abnormal neurological examination found in around 23%. The complications and comorbidities affecting neurodevelopmental outcomes. The common genetic syndromes associated with CHD affecting neurodevelopmental outcomes. The genetic syndromes are seen up to in 30% of the patient. Most common will be the Down syndrome and 22q11 deletion. The Down syndrome plus CHD, median IQ is less than 50. Though with atrioventricular septal defects, outcome may be better. Only the motor domain on the BSID testing was lower in children with the atrioventricular septal defect as compared to those of the normal heart. And the children with the 22q11 deletion and the mean IQ is reported to range from 70 to 80%, and the higher incidence of attention deficit and hyperactive disorder later in life. The complications will be the seizure and stroke. First, seizure may occur for no identifiable reason, but sometimes may secondary to the acute ischemic or hemorrhagic event. And the EEG seizure associated with a mean reduced psychomotor developmental index score on the BSID testing at 1 year. Increase risk of later abnormal brain MRI. Perioperative seizures most consistently related to worse neurological and neuroimaging outcomes. Then second complication is stroke, is seen on MRI up to 10 to 30% of the infant with CHD, both before and after surgical repair. More frequent with the low birth weight, low intraoperative hematocrit, and high admission blood pressure, and often not clinically evident in neonatal period. Their outward signs of the stroke can be masked by pharmacological sedation or paralysis. And it is often not detected for lack of good repeated cranial USG, and can cause later motor deficit depending on their site and neurodevelopmental problems. On follow-up, in case of tetralogy of Fallot, the symptomatic patient should be followed up to 1 to 2 year lifelong, and the cardiac catheterization if required if any residual lesion is suspected, and may also be required for percutaneous interventions such as stenting of the pulmonary artery branch for stenosis. Then long-term follow-up every 6 to 12 months is required for patient with residual VSD shunt, residual obstruction of RVOT, and residual pulmonary atresia obstruction, and arrhythmias or conduit disturbances. And the significant pulmonary regurgitation may require surgical insertion of the homograft pulmonary at the pulmonary wall at later time, and due to in pulmonary regurgitation due to stenosis of the main pulmonary artery or the branch of pulmonary artery. The relief of pulmonary artery stenosis by balloon or stent procedure or both may improve the pulmonary regurgitation. And the surgery indicated in case of PR when the child is symptomatic or when it is associated with significant TR, poor right ventricular function, or progressive right ventricular dilatation. Arrhythmias. These are related to persistent right ventricular hypertrophy as a result of unsatisfactory repair. The complaints will be the dizziness, syncope, and palpitation. And a 24-hour Holter monitoring event recorder or exercise test may be needed in case of arrhythmias. The pacemaker therapy is indicated for surgically induced complete heart block or sinus node dysfunction. And the cardiac MRI needed in case of asymptomatic patient, baseline study should be performed 10 years after surgery with periodic follow-up. Then infective endocarditis prophylaxis is indicated in case of non-corrected patients, patient after surgical repair for 6 months, and the patient with the percutaneous or surgical pulmonary wall replacement. And advised to maintain a good oral hygiene even after 6 months of surgical repair. Then in case of TGA, all the patients need follow-up lifelong. The follow-up interval depend on the age, type of surgery, and residual defect. In operated patients with no residual defect, follow-up visit should be at 1, 3, and 6 months after surgery, yearly after that till onset of adult life, and every 2 to 3 yearly thereafter. Follow-up every 6 to 12 months is required for possible progression of AV conduction disturbances and arrhythmias or worsening of anatomic tricuspid wall regurgitation. If pacemaker is implanted, the routine pacemaker care will be required, and the activity restriction is indicated if hemodynamic abnormalities persisted. Then follow-up visit should include the clinical assessment, ECG, and echocardiography. And the infective endocarditis prophylaxis recommended in patient with cyanosis for 6 months after definitive surgery, and in case of conduit or other prosthetic material during surgery. And the all patient advised to good oral hygiene after 6 months of definitive surgery. Then patent truncus arteriosus follow-up is every 4 to 12 months required to detect the late complications such as progressive truncal wall insufficiency. The truncal wall repair or replacement will be done, and a small conduit need to be changed to a large site, usually 2 to 3 years of age. Then another is calcification of the wall, which may require reoperation. Then ventricular arrhythmias due to right ventriculostomy. And patent truncus arteriosus, balloon dilatation and stent implantation in the right ventricle to pulmonary artery conduit can prolong conduit longevity and delay need to replace the conduit surgically. The patient should not participate in the competitive strenuous sports, and the infective endocarditis prophylaxis is recommended after surgical repair. Then TAPVC. After surgery follow 1 month, 6 months, and then annually for 5 years if there is no residual defect. The evaluation every 6 to 12 months for the late complications, such as pulmonary vein obstructions, 6 to 12 months after repair, and at the anastomosis site or delayed development of pulmonary vein stenosis may occur in about 10% of the patients and requires reoperation. Pulmonary vein obstruction requires cardiac catheterization and angiocardiography. Then the second is atrial arrhythmias, sick sinus syndrome, which require medical treatment or pacemaker therapy. Then no activity restriction unless pulmonary venous obstruction occurs, and endocarditis prophylaxis is usually not needed unless the obstruction is persistent, and advised to maintain a good oral hygiene. Tricuspid atresia, low salt diet will be required, and medications in some patients need digoxin and diuretic therapy, AC inhibitors, and third is aspirin or warfarin to prevent the thrombosis in right atrium. Then patients should not participate in competitive or strenuous sports, and 5-year survival rate is 80% and 10-year survival rate is 70% in tricuspid atresia. Then in case of Epstein's anomaly, frequent follow-up is necessary because persistence of arrhythmias after surgery occurs in about 10 to 20%. Problems associated with tricuspid valve surgery that requires reoperation. Antibiotic prophylaxis for endocarditis should be observed, and the patient should not participate in competitive or strenuous sports. Okay. Thank you.
Thank you everyone for a great presentation. I have a question for Dr. Deepak from MRR Hospital. Hello, am I audible?
Yes, ma'am. Hello.
Yeah. So I just wanted to ask that are there any reports or recommendation or studies for the use of other pulse oximeter apart from Masimo for pulse oximetry screening?
Hello.
Hello. Hello. Yeah. Am I audible?
Yes, ma'am.
So my question was regarding the technology for the pulse oximetry screening. Are the other technologies explored for the same?
No, ma'am. It's regarding Massimo only.
Okay. Because that is a practical problem in the country, because the Masimo technology itself raises the cost a lot for a
Yes,
simple
ma'am.
pulse oximeter.
Yes, ma'am.
And a lot of pulse oximeter also have the technologies which they take care for the these artifacts for the low perfusion. They do not have a specific Masimo tag, but then they have their own specific technology with respect to it could be fast or other with
Ma'am,
good monitoring.
usually in the India we use, ma'am, Nelcor from Medtronics and Oximax, which is more cheaper than Massimo.
Yeah, but then yes, Nelcor is much cheaper. But then there are other machines, good brands, which also have the technology for the accuracy of the detection of the signals with low perfusion states or others. So I think it is something which should be explored in India itself as a head-to-head comparison, because
Yeah.
that is a practical limitation with respect to cost.
Yes, ma'am. Because in periphery it is not possible to buy such expensive Massimo machines.
Okay, thank you.
Okay, ma'am.